and WPS Health Solutions. Wisconsin Health News is a nonpartisan, independent online news service. In addition to hosting events like these, we also publish a daily email newsletter. If you are not yet a subscriber, I encourage you to sign up for a free trial. You can do so by signing up through the event evaluation, which we'll send out after today's event, or you can also sign up on our website at wisconsinhealthnews.com. An extra thanks today to the Wisconsin Medical Society, today's featured sponsor. We are very grateful for their support. And here to say a few words is Board Chair Dr. Jerry Halverson.
Thanks, Tim. Thanks for organizing today's meeting on such an important topic. I'm Jerry Halverson. I'm the Chief Medical Officer at Rogers Behavioral Health, and I'm the Chair of the Wisconsin Medical Society's Board of Directors. The Society advocates for physicians and their patients, promoting healthcare policies that allow physicians to practice efficiently and effectively, doing what they are called to do, helping care for patients. The Society has more than 10,000 members throughout the state. They range from being solo practitioners to working at large integrated health systems and everything in between. While there's great employment and political diversity among this many members, they all share a common reason for joining the medical field, the honor of being able to take care of people. Healthcare and medical science is constantly evolving, and physicians are driven to find ways to make our nation-leading healthcare system even better. That's why we're happy to be the lead sponsor for today's webinar on emergency detentions and the challenges that physicians, patients, and law enforcement currently face. Physicians are all about tackling complex challenges head-on, sifting through the facts and data to help find the best path forward. So the Wisconsin Medical Society is pleased to partner with the Wisconsin Health News in helping to present this webinar series, which helps inform policymakers, the media, and the public on ways to continue improving healthcare in Wisconsin. We look forward to learning more today as Tim interviews our panel of experts. Thanks, Tim.
Thanks, Dr. Halverson. Thanks again to the Medical Society for all of your generous support. So now I'm going to hand it over to Sean Kirkby, our assistant editor of Wisconsin Health News, who is going to be the one interviewing today's panelists. Sean is moderating today's event. Sean, I'll let you take it from here.
Thanks, Tim, and thanks to our panelists and viewers for joining us. We're going to be discussing Wisconsin's emergency detention process, which is the way the state treats those who are in mental health crisis and deemed a risk to themselves or others. It's a complicated process that's both medical and legal, and has a wide impact on many different groups, including patients, law enforcement, healthcare providers, and counties. We assembled a few of those folks here today to talk about what reforms they see needed. And I'd like to start with you, Kim. You've experienced this process as a patient, and I was wondering if you could share a little bit about what this was like to go through.
Well, I'll start with saying I'm a mother of 5. I'm a certified peer specialist, and I had 2 emergency detentions in 2020. It had been 20 years since I had had any symptoms of my bipolar 1 disorder, but I found myself in crisis in May and was taken by the police in handcuffs to, first I think I went to Meriter, and then I went to Winnebago. And then again in December, I was, it feels like you're arrested, but emergency detained once again. And I went voluntarily that time, but they put me in handcuffs anyway and take me back to UW. So I would say the experience is traumatizing. I would also say that there's a better way. There was one in the first time I went to UW in December, police came to the point where I was in crisis. They asked me which hospital I wanted to go to, and I was able to go to the hospital without being in handcuffs, but in a police car. So I think that people can, I think there's a better way to handle people that are in crisis and are not harming themselves and aren't a harm to other people.
When you, well, thank you, Kim, for sharing that. And when you were going through this process, you talk about looking for a better way. What would you have liked to have seen and received in terms of care that you didn't get?
I would like to see more of what happened to me December 26th, and that was police came to the place where I was in crisis. Police asked me, where I wanted to go. I did have to go in a police car, but I was not handcuffed. I would like to see peer specialists being a part of that process. I recognize that would, I would like to see peer specialist a part of a crisis team. I would like to see peer specialists in the ER, and I would ultimately like to see peer specialists on the floor of psychiatric hospitals. Because I think if you have lived experience, you can be with people in that time of crisis and offer hope and hopefully stabilization.
When you left the hospital, did you have a plan for how you would be able to continue to get support in the community, and how did you navigate leaving that process?
That's a great question. When I was in Winnebago, there was nothing offered to me when I left. I was on commitment for 3 months, which I didn't, it wasn't explained to me what a commitment was. I, and then in Winnebago, at UW, I was also not given like any support as to what to do after leaving. But because I'm a peer specialist, I know about comprehensive community services. So I took the time on my own to make that phone call to comprehensive community services and to get support for when I left the hospital. And I'm currently in with Chrysalis for comprehensive community services. And I think that is a wonderful program, but no one offered me that, and no one directed me in that way at Winnebago or at UW.
All right, thank you, Kim, for sharing that. And I wanted to switch to Attorney General Kaul. Attorney General, you've been involved in this process and looking at ways of reforming it. Can you just elaborate a little bit about the role that law enforcement plays in this process and what impact it has on police departments across the state?
Yeah, so first, thank you to Wisconsin Health News for having me, and it's a privilege to be here with these other panelists. This is an issue that my office is involved in because law enforcement officers came to us and said, we are spending very significant resources responding to emergency detention cases, and the process that we have in Wisconsin isn't working. And as a result of that, we've worked with a variety of different stakeholders to analyze the system and to look at ways that it's problematic and ways that we can improve the system. And what we found is that the system that we have for emergency detention in Wisconsin is really broken. And it's based on an outdated model of what kind of mental health care should be provided to somebody who is in crisis. And it's a system that is desperately in need of reform. Right now, law enforcement officers get calls for service. And often what happens is there's a call that says that somebody is in crisis. First of all, hopefully before that happens, there should have been some intervention from social workers or from somebody who's an expert in psychology or psychiatry, because by the time somebody's in crisis, the response becomes more difficult. Secondly, law enforcement officers, for the most part, are not specifically trained to work with people who are in crisis. There are some great crisis intervention team trainings out there, and there are some officers who do have that training, but they're not the folks who we would normally assume would be responding to a mental health crisis. But that's the system that we have in place right now. And then officers need to work with the person who's in crisis to figure out an appropriate solution and try to stabilize the situation. In much of the state, there is only one facility of last resort that's available, which is Winnebago Mental Health. There are a few counties that have county facilities, but Winnebago Mental Health is where most law enforcement officers will be transporting somebody in Wisconsin. But before somebody can be brought to Winnebago Mental Health, they first have to go through what's called the medical clearance process to confirm that they don't have an acute illness that may need to be treated immediately before they can go to Winnebago Mental Health, which doesn't provide full healthcare services, just mental health services. That process takes a while. It can be inconsistent. And then after that, transport to Winnebago Mental Health happens. And then court proceedings may happen after that. And once you start adding all those things up, that's a significant amount of time that law enforcement is spending responding to these situations, which means time they're not in the communities protecting public safety. And it's a significant amount of time, as Kim was referring to before, that somebody who's going through a crisis is spending not getting healthcare, but instead being moved from place to place and often in the back of a squad car and in handcuffs. So this is a system that needs reform, and it's one that impacts all sorts of folks, including law enforcement, people who are in crisis, and many others.
Can you elaborate a little bit on how COVID-19 has kind of impacted this over the past year? Have you seen or heard about more emergency attentions, and what kind of precautions have people had to take when it comes to transporting folks in the throes of crisis across the state?
We don't have data yet with respect to the impact of COVID on emergency detention specifically, but there are a couple of clear impacts from this. One is just as a safety matter, in many situations where law enforcement is responding, and this isn't specific to the situation where somebody's in crisis, but just in general, the idea of keeping 6 feet of social distance is not always available. And so officers are often putting themselves in situations that are dangerous in this pandemic environment. And they don't choose whether the calls they're responding to are calls where somebody's wearing a mask or not. So first of all, there's just heightened risk to safety because of COVID. And then secondly, there has been obviously increased social isolation as a result of COVID. That can impose strains on mental health. It imposes strains on people with substance use disorder. And it's my expectation that what we will see ultimately is that there are more cases where somebody's in crisis now, but also as we move away from the pandemic. And it's one of the reasons that investing in behavioral health care now, I think, is so critical as we prepare for the aftermath of the pandemic.
You mentioned that you've convened a large number of stakeholders to work on a framework for this with a focus on a holistic approach. Can you talk about what's gone into developing that framework, and what are your broad goals for reform?
We held a summit on Halloween of 2019 where we brought together a variety of people. We had a speaker who was a peer specialist, much like Kim is, who spoke about her lived experience and about her work at a peer respite center. We had a speaker from the Department of Health Services, and we had other folks who presented their views on these issues as well. What we have tried to do is bring together the many different people who are involved in this process in various ways, and that includes the Wisconsin Counties Association, Wisconsin Hospitals Association, ER and psychiatric doctors, NAMI, which advocates for people with mental illness, the Public Defender's Office, corporation councils were involved in our discussions, and others, to identify solutions that we think can improve this process. And the solutions that we have identified and proposed as part of this coalition are really focused on two goals. One is to divert more cases away from emergency detention so that it can be avoided whenever possible. There are cases where somebody may be a danger to themselves, but not others, and an environment that is less restrictive than an emergency detention environment saves time and resources, certainly, but most importantly, I believe is going to lead to better outcomes for the person who is in crisis. Secondly, we also think we can improve the process by creating some more uniformity in how emergency detention works, by trying to take advantage of things like remote communication so we can minimize some of the transport that happens, and through other steps that we believe can help make emergency detention more effective when it does happen.
Thanks, Attorney General. I wanted to move to Senator Bernier. You represent a part of Western Wisconsin, and you've been introducing some measures to address this process. Can you talk about how this process impacts your constituents and district?
Yes, this was a discussion that I've had with the Northwestern Region Department of Human Services in all of those counties for many years. And we do have what's called Northwest Connections. Law enforcement will call them, they'll evaluate the condition of the patient and what's going on and help them assess what is the best way to care for this individual and what options are available to them. So there's various options. I understand we could use some better crisis diversion rather than just using Chapter 51. But generally, I am told that with Northwest Connections and the social workers and psychologists available there, that it is the last resort to Chapter 51 an individual. But what I saw is most of the people from our area of the state a great number of them, and I have the data that ended up going to Winnebago. Winnebago is overwhelmed. They're having difficulty keeping up. The stays are much longer than if they're treated in a hospital with surround care. So if there's other conditions, also the human being is a very faceted thing, and where it's not just the mental health. You can't isolate the mental health. There might be job issues. There might be a health issue. There might be dental issues. So the hospitalization portion looks at the whole being and not just the mental health aspect. So made some phone calls, found a good partner in HSHS that was willing to expand the beds for a one-time investment from the state of Wisconsin taxpayers of $15 million, would provide 18 juvenile health beds, which are in dire need. Something in the news recently at Winnebago in regard to a juvenile. And so we have a huge need in our area of the state. And the best thing I know you can't have a facility in every single county or every single community, but if we can work regionally to provide at least closer options for our citizens in our area of the state, and then the additional adult beds would be at in Sacred Heart in Eau Claire, and then the juvenile beds would be housed in Chippewa Falls. And so it's not the entire answer. I've never stated that it was the entire answer, but it is just part of the picture of the overall healthcare needs and the overall needs for our citizens, because we are very complicated, and human beings are very complicated.
Senator, where does this plan currently stand in the process? I know it got through the assembly last year, and it's had kind of a long, complicated history in the legislature. Can you sort of elaborate a little bit on that and where things are currently?
Well, I put it in the budget last session, and unfortunately the governor vetoed it. And then we had lots of conversations with the governor in his office saying, oops, this was like really needed. And we met with the Department of Human Services, DHS from Madison, and they came into a meeting we had in Chippewa Falls. Anyway, all in all, we all came to an agreement that this is really needed. Regionally, maybe another option somewhere else in the state to take pressure off of Winnebago. And so we were supposed to have a hearing today, as a matter of fact, but it was moved to next week on the bill. And so we're going to hear it again. The money is currently in the building commission, so it's not like it's new monies. So that's why we don't need to take it through the budget process again. So we're hoping that we can get this off the ground and get more people help. I know COVID has caused some issues because of having to socially distance, and there were fewer beds available due to COVID-19, but telehealth has been very helpful. I know that is one of the issues that you've been talking about. I think that has been, I think we learned in the pandemic, if you want to pick out something good about it, that we can do things and meet and take up challenges virtually now that we weren't able to before. And telehealth was on the forefront, but now really pushed and to utilize it more safely and efficiently, especially with the worker shortages we have in psychologists, psychiatrists, and psychotherapists. So I think we're on the right path.
Excellent. Well, thank you, Senator. I wanted to move to Kit. Kim shared her experience at the start, and I was wondering if you could talk a little bit about how reflective that is of what people go through in this process, and if you could also talk a little bit about how it affects families.
Yeah, I believe.
It looks like you're muted, Kit.
I thought I unmuted myself and I muted myself. I think it's very, it's very typical. I think it's 100% her lived experience and needs to be respected as such to start with. Everybody's experience is unique. And the system as it is now isn't built to deal with that. I'm glad to hear people coming into the circle of realizing the system is broken and that we need to do more for people who are in mental health crisis. I think this opportunity provides us a time to go big and not make the criminalizing people with mental illness and putting them in institutions more efficient and more effective. The time is to stop doing it. And that it's over $1,000 a day. I'm not exactly sure what it is now, but it's over $1,000 a day to keep someone in Winnebago. What can we do with that money that would put it in upstream into people who could voluntarily actually get services before they're at that apex of a major crisis, to help them not need to go inpatient. So my goal is to do away with inpatient beds, to move to regional, more open settings that aren't so much based on coercive treatment. Coercive treatment doesn't work. It's much better for the recovery of an individual to get them involved in their treatment. And that doesn't work under the current system. Criminalizing them and putting them in handcuffs or in a squad car, taking them hundreds of miles from their home doesn't work. None of these are conducive to mental health. We have an opportunity to look at it. This is long ago, they decided that mental illness was a public safety issue instead of a public health issue. We need to revert to it being a public health issue. And that means looking at the system a better way. It certainly means reducing the role of law enforcement. It reduced the forced treatment, reduced inpatient settings in favor of more regionalized, open voluntary settings, putting consumers in the driver's seat of their own treatment. These are all things that we're at, and if we all agree it's broken, let's not just put more duct tape and baling wire on it and keep moving down the road. Let's just stop and let's look at it. I think for families, it compounds the crisis because you have the child in crisis, and now you have a family who's lost control. They first of all, a lot of times you hear of families that can't get treatment for their child who is in danger of hurting themselves generally. So there's that issue that some people actually go towards a commitment because that's the only way they can access treatment. That's not right. We should be able to get it upstream, help people to stay in their communities, keep their relationships, keep their jobs. Then if they do get an emergency detention that moves forward, then the parent loses all contact and control of the situation and their child. I know there's sometimes that there's therapeutic reasons to have some kind of boundaries, and I'm not getting into that angle of it, but I know many parents who were regretful they ever made that call in the first place because it ended up making matters worse instead of better. We need to rethink the whole system. We need to shift the paradigm to public health. And some of these measures will make it a little bit better around the edges, but they're not going to. We're going to be back here in 10 years talking about the same kinds of things.
Thanks, Kit. I was wondering, can you talk a little bit about, you mentioned these court kind of proceedings, the commitment process to get treatment. How do these court proceedings affect treatment and patients?
Well, no one goes to court to get a gallbladder operation to decide if that's what it should be or shouldn't be. This is back into this is treating mental health and mental illness as a public safety issue. It's traumatized. Not only is the initial contact with law enforcement traumatizing, but the whole court system is traumatizing. You are, I don't care what they call you, you feel like a defendant. You feel like you're defending yourself, and what you're thinking and what your issues are right now in a way that, well, if I say this, is that going to get me stuck here for another 7 days? Am I going to lose my job? It's just not the way. It actually stands in the way of getting treatment. It doesn't add to it. Then at the other end, because the commitment process actually moves really fast, and commitments can be over in what in legal court system is a very short period of time. An initial commitment can be 6 months long. So if you are treated poorly, the law is not followed, you cannot even get an appeal done with that, because it will be mooted out, because by the time you get to the appellate court and the transcripts are ordered and they respond to this and they get 30 days for that, the commitment's over and it goes away. So it never even gets brought to the light of day. So the court system is an enabler of honestly the lack of treatment and the poorer quality of treatment that people are able to access when they're at a point in their lives when they're probably the least effective self-advocates that they're going to be. So that's another reason for peer support for people who aren't in an us-them dynamic with the patient. There's just every angle of this should be looked at, which doesn't lend itself to quick solutions. So
thanks, Kit. I wanted to move on to Todd. Can you talk a little bit about the role of counties in this process and major issues that you're facing when it comes to addressing mental health crisis?
Sure. Thank you again for this this webinar. It's I think this is a helpful topic to explore. There's a lot that's already been discussed. You know, as a county, we are that 5142 board where we authorize the emergency detentions to take place. In my role in Dane County, we do contract with the provider, much like Senator Bernier talked about in the Western region, to act as that crisis worker, that crisis provider, and work hand in hand with law enforcement on those emergency detentions. In Dane County and Madison, we're blessed to have a unit of dedicated officers who are mental health officers who focus on this particular population and try to work in the most humane way possible. But it is a difficult situation once we reach that situation. I also am here as a member of the Wisconsin County Human Services Association, one of the chairs of their behavioral health committee. And so I have the opportunity to talk to a lot of different counties about how they're creatively working within this system. A lot of things that previous speakers have already mentioned are things that come up in our meetings pretty regularly as possible solutions. Having a central mental health institute, for us, it's a 2.5-hour drive to get somebody the care that they need is really a huge barrier. What we need are more local options, not just for that inpatient care. When somebody is in desperate need of that, and there are occasions where people do need inpatient care, but the more locally that can happen, the more effective that recovery is going to be and how it's going to get started. We also need improved payment and options for community-based care before we reach the point of crisis or following a point of crisis in a person's life. We need good evidence-based, community-based care that we can help people find their path toward recovery. We try and do things in counties, sometimes on a shoestring, and it sometimes doesn't meet the needs of the people where we're implementing evidence-based practices according to what's been tested out, what's been researched nationwide. We need a system that's more capable of reimbursing for that cost of care in the community before we have to reach that point of seeking inpatient options for individuals when they need that period of stabilizing.
Dane County is currently working on its own mental health triage and restoration center, which was planned for opening this year. Can you elaborate about what this center would do and how it would sort of help you guys address these issues?
Well, thank you for raising that. Let me clarify. We do have a request for proposals out to hire a consultant to help us plan that. Somebody mentioned that there are no quick solutions here, and we can't just put up a triage and restoration center without doing a full evaluation of what does the rest of our crisis care continuum look like? What does our community-based treatment continuum look like? And how does a triage and restoration center fit into that? So as we talk about those regional centers, yes, it's a great thing to have things more locally, to have resources more locally, to have those options available, but they have to be the right level of care in the right place at the right time for people. And we need to plan in order to make sure that that happens. So we are starting at step one to hire a consultant to help us develop that implementation plan of where the place can be, what kinds of services does it need to have that fit into the rest of the continuum that we have in Dane County. And each county actually needs to, and each region needs to really self-examine what do we have available, what questions and what holes do we need to fill before we can start erecting these regional options and other options.
Thanks, Todd. I wanted to move to Pete, who's also involved in a regional approach to this. Pete, can you talk a little bit about the development of this emergency mental health center in Milwaukee, collaboration between healthcare providers and the county? What's kind of led to this?
So, this really is it's as you mentioned, a collaboration between the 4 healthcare systems in Milwaukee County and Milwaukee County themselves. And, after a number of years of discussion, Milwaukee County came to the conclusion that they could no longer operate the inpatient hospital and the crisis or the psychiatric ED. And collectively as a community, we've been working on behavioral health issues in good partnership, I would say, for the last 15 years. And I do feel like because there was some trust that had built up over time, when we really evaluated what we need to do in this community, with Milwaukee County's decision, we really felt like what we needed to do was to build a center that would provide many of the functions that PCS provided, only that it would be located closer to where the people are, and the building itself would be designed for the work that we're doing, which would be different, from the situation that PCS is in currently. And it really is, part of this is because of many of the things that have been said today, about the way that these can go bad, and it turns into a really, it's a bad experience to begin with, but it turns into a horrible experience. And so, the reality was, I think collectively we all felt like there was so much inconsistency in how the various ERs in the community manage mental health patients that we felt like it was better for the community to have a place where we know that people are capable of working with patients in crisis, that are capable of working with people with dignity and respect, to really help stabilize the current situation and get the person to the best place possible. The other thing that I would add to that is I agree that peer supports peer specialists are a big part of this, and we have not used them as much as we should. And I think that that's something that we need to change.
When it comes to this center, where does it stand currently? Can you give an update on its progress?
Yeah, so right now we are working on, so the way that things came together, we put together some non-binding letters of agreement. Advocate Aurora was asked to be the manager, the operator of the new facility. So we are now in the process of developing, management services agreements as to how we'll do that, how we will work with the physician group. Those are sort of the main kind of pieces that need to get done. Once those are completed, at that point, then we would move forward with the binding agreements. The corporate, all the legal work around setting the corporation up has pretty much been done. So things are moving along. It's there's still a lot of work to be done, but people are working together well, and it's coming together.
And do you think that this is an approach that could be replicated throughout the state? I mean, have you received any feedback from folks around Wisconsin about what you're doing and interest in it?
There has been interest, and this is really it's Milwaukee County, but it's more regional in nature. Just as a provider of behavioral health care, we've been involved with emergency detention work for many years, probably 20 or more. And so we work closely with many of the counties, surrounding Milwaukee County, and there are definitely, opportunities, I think, to do things more regionally. So for example, we may, for patients that, are hospitalized under Chapter 51 from, Walworth County, Kenosha County, other counties outside Milwaukee County, we are the detaining facility for those counties. And as we look at this larger system approach that we're talking about, we think that there's much more opportunity for a regional approach to this. And, the traveling up to Winnebago from, really most parts of the state is just it's a huge burden. And I agree with what others have said. This process is broken. It needs to be fixed. Unfortunately, we're going to be fixing the car while we're driving it down the highway. That's the
Thank you, Pete. Thanks, Pete. Attorney General, the governor's budget would fund 2 regional crisis assessment centers, and there's also some money for funding regional crisis stabilization facilities. Can you talk a little bit about how these fit into your coalition's framework?
Yeah, absolutely. So one of the things I talked about initially was the importance of diverting more cases. And the way that the stakeholders who we talked to sort of identified as ways that you can have fewer cases result in emergency detention is by investing in a continuum of care. In some parts of the state, there is a wide range of different healthcare options, but in other parts of the state, there aren't so many options. And when you have limited options, you may end up with somebody in care that's far more restrictive than is appropriate for them. What I would like to see is first, a crisis response that in as much of the state as possible involves not just law enforcement, but also somebody who has a background in working with folks who are going through mental health crisis, whether it's a social worker or somebody with a background in psychology. I think that can help de-escalate situations when the initial response occurs. And it provides somebody who can do follow-up with folks after that initial contact that happens when somebody's in crisis to try to prevent a future crisis. Then I think having a range of options for care is important. And I think one very low restrictive option is peer support. As you've heard discussed, that's a way that people can get counseling. They can discuss the experience that they're having with somebody else who's had a similar experience. I think at an intermediate level, like the crisis stabilization facilities you're discussing, that involve medical intervention, but not a restrictive environment, can help as well. And then regionalizing the care when there are emergency detention beds has been discussed is important. Also having more investment in programs that are designed to address suicidality in people around the state is important, and allowing assessment to happen on a regional basis before somebody's been transported across the state can help as well. So I think there's a lot that we can do to invest in a continuum of care. And I also think it's important to emphasize that while that does address the issue we're discussing today, it also helps with people who have broader mental health issues when they need treatment. Because by getting people the services they need earlier and having more options available, I think we'll have fewer people in the crisis situation later on in the process.
A question that came up from our viewers, and it's been talked a little bit about this panel. What are your thoughts about reforming the system to remove law enforcement from it? As this framework moves forward, what role do you see for law enforcement in the legal system in it?
I think there are a range of options that we should look at, and different places have been trying new things. I'll mention a couple models that I think are really encouraging. In Eugene, Oregon, they have a program called the Cahoots program, where most of the responses to crisis calls are not law enforcement responses. Denver has a similar model, and Madison is working on developing a similar model as well. I think when you have calls where you can confidently have a non-law enforcement response, I think that's the ideal way to respond. The challenge that we have is the way this usually unfolds in practice is that a law enforcement agency will get a call saying somebody is in crisis and they are threatening to harm themselves, or they're threatening to harm somebody else. And having a law enforcement officer at least nearby as part of that response, in those cases, I think is the safe thing to do to address the crisis situation. But I also think this is something we need to keep looking at and evaluate how other models are working, so that the type of response that we are having to these situations is one that's appropriate for the situation.
And another question we got from the audience, it's going to take some money to accomplish a lot of these reforms. Where does that funding come from, and how long do you think it's going to take to build up this kind of infrastructure?
I think there are a few different ways that we should think about funding sources. First, it's important to note, and this has been discussed, that there are major costs to the system as we currently have it. There are costs in terms of law enforcement time, county time. There are major costs, as Kit mentioned, when somebody's in emergency detention, there's a very significant healthcare cost. And so by adopting a better system, there are a lot of cost savings to be had. The budget that has been proposed would provide some of the investments in these kinds of facilities. And this is an area where I think we're going to need to invest in the long term anyway. And then I'll mention two other sort of potential sources of funding that are shorter term, but I think are important to consider right now in this current environment. One is there's a very significant relief bill that is about to be signed into law that's going to provide significant resources to the state. And I hope that one of the things that is considered for those resources is these kinds of investments. And then that legislation also contains a sort of one-time offer for us to bring in enormous resources if we expand Medicaid in Wisconsin. $1.6 billion the state would save over the biennium. We could use those resources in all sorts of really valuable ways. So I think there are options out there, but this does require an investment of resources. There's no question about that.
Thanks, Attorney General. Senator Bernier, you're on the Joint Finance Committee, which is just in the early stages of the budget process. Governor Evers has proposed a slew of investments in mental health crisis services. Do you support those provisions in the budget, and what do you think of them?
Well, it's complicated to say the least. Medicaid expansion, you can't spend the whole thing on other things because you have to provide health care for that 38% of people who need healthcare coverage. So it's not clear to me exactly how much would be left over to spend on other things. So I agree we have to invest in mental health care as well as other priorities in the budget. But I want to point out, I assume the whole panel's from the southern part of the state. Is that a fair assumption? So when I hear that Milwaukee has this great plan, and good for you because you have lots of different organizations to partner with. When you get, and I'm always preaching about the life up north. We have a different set of circumstances. We can't create a facility in one county or two counties. We don't have the population. Currently, we have a crisis stabilization facility with 4 beds in Chippewa County, but they don't have enough referrals in order to keep those beds filled. It's Aurora Community Services, I think it's called, that runs that facility. So they're taking in folks from our managed care organization. So when we talk about how complicated this is, it is more complicated than you actually realize. And so I get on the website and I look at all the mental health care and the healthcare services in just Chippewa County to gauge myself as to what's available. There's a lot of things available out there, but I just want to emphasize that Chapter 51 for all of our law enforcement and for our counties is the last resort, not the first resort, the last resort, because calls are made prior to that. But a law enforcement officer can't ignore it, and we don't have the staff or the capability to send someone with the law enforcement officer. But the upside is this. Sacred Heart brings in Chapter 51s. There's quite a few of them that go there. Half of the people that are brought into the emergency room decide to stay there voluntarily. And then the other half that go up to the floor that are under Chapter 51, half of them decide to stay there voluntarily because they are getting help. And so it makes it sound, I don't want everyone to think that the people who are brought in for help are all there unwillingly. They're not. Most of them are there unwillingly, but decide once they're there that these folks here in the mental health profession are there to help them. And so we need to continue to work on this. It's like anything we've worked on in the legislature, kind of over and over again, and getting everyone to weigh in. But what works in Milwaukee or Madison or Denver, Colorado will not work in Dunn County, Chippewa County, Barron County. And so we need to understand that whatever we come up with, one size does not fit all. Thank you.
Earlier in the discussion, you had brought up that you see other things that need to be done to this process beyond the beds at the HHS facilities. Can you just talk a little bit about what other mental health investments that you'd like to see in a state, particularly addressing workforce, which I think would be a concern in your district?
Yeah, so we have, we've had a couple of bills that would encourage people, individuals who are in their training period of their psychology degree, that they could start working and being paid for their training, part of their training. We just need to encourage, like there's a worker shortage in healthcare in general. So I think we're going to have to use telehealth. We're going to have to just think outside the box. That's where I rely on the professionals, because as a legislator, I've got 99, maybe 199 different issues to deal with. So we're open to any suggestions to make everyone be able to work more efficiently and more effectively, knowing full well that we're always going to be short of staff. So if you create a new facility, just bear in mind, I went to went to a current facility who's already providing that service, as it sounds like Milwaukee has done. Because it's, I would say, nearly impossible to build a new facility, get psychiatrists, psychologists, and psychotherapists and social workers, enough of them on board to even open a new facility. That would be a challenge in and of itself. So I look at it as partnerships and how we can all work together with the resources, many of the resources we currently have available to us.
Thank you, Senator. Pete, I wanted to move to you as we're talking about this healthcare workforce. How has telehealth, how can telehealth play a role in this process? And do you see that as a potential solution to some of these mental health workforce challenges?
Yeah, I do think that telehealth has been really the silver lining of the pandemic has been telehealth, and the ability to reach people with telehealth, with these services. And I can tell you that within our system, we began telehealth almost immediately after about a year ago. And we began to survey not only the patients, but the providers as well at the very beginning, because one of the things that we thought was that over time, I've thought about telehealth for years, and over time, that if people were struggling with the technology, they would get better at the technology, and they would find the service to be a better service. And what we have found is exactly that. The patients are very satisfied with the service. It's very close to, they feel that it's very close to an in-person service. We have some clinical results that would indicate that it's very close to an in-person service. I really feel like this is, one of the things that we have to do first to help mitigate the problem with the shortage of providers, the problem of distance. I agree with the senator. You can't be building a facility in such a small area. That's one of the struggles. We can use telehealth as a linkage for this. So if there were one thing that we could move forward with that would have the biggest impact immediately, I think it's telehealth.
Got it. Thank you, Pete. Kim, I wanted to come back to you. We talked a lot about peer support, and you're a peer support specialist. Can you talk a little bit about what type of care and support do you provide to folks, and how you sort of envision this working within a broader spectrum of care?
The definition, or kind of what we say in the peer support world, is that we offer hope and recovery. So we come alongside people who are in crisis, or who are or just need our support, and just support them where they are and help them get to the next level. And as far as how it relates to emergency detentions, I'll just say again that I do really believe that if we could include peer support in some of these other areas, like on a crisis team, in the ER perhaps, or on the floor of psychiatric hospitals, I think that would help people in the process. I do know that both the times that I was hospitalized last year, once I started feeling better, once I started stabilizing, I started peering other people on my floor. I started encouraging them to get comprehensive community services when they left the hospital. And none of that was done for me. So I think having someone on a floor, or in the ER, or at that crisis call would really help with people in their crisis.
Thanks, Kim.
Thank you.
Todd, I wanted to move to you quickly. Can you talk a little bit about the role that counties can play in prevention and offering those types of services?
Well, it comes back to having that community-based continuum of care available for those who need it. And it is complicated to pull that off, not just because counties aren't often the only game in town. In some places they are, but in other locations, other larger locations, we're weaving our services together with other healthcare providers and healthcare funders, which makes it a complicated system to navigate for people. So that's something that we need to pay attention to, is how do we help people navigate, not just from an inpatient stay back to the community, but between community providers. We also have to pay attention to all the different kinds of populations who come across our crisis intervention system. We work with people who have symptoms of dementia, folks who have intellectual and developmental disabilities who come in contact with our crisis continuum. And we need to be able to serve them as humanely as possible as well, and to help stabilize the situation. It's a different skill set and it takes a different expertise, but we need to build that up as well. So local counties do understand the needs of their populations. They should be looked to as the experts to help develop those resources as best we can, knowing what we know and what we see on the ground every day.
Thanks, Todd. Kit, I want to come back to you. Todd just mentioned the need for developing services for those with dementia and disabilities. I was wondering, that was also an audience question or viewer question that came up. Can you talk about the broad spectrum of patients that are affected by this process and what you sort of see in terms of those fields of those with disabilities and dementia?
Wisconsin has two parallel systems. One is the system for mental health crisis. I'm talking about the crisis systems now. And now there is also in statute a crisis for developmental disability crisis services. That system is grossly underfunded. It's hard to get services. Someone with dementia does not have a classic mental illness that we should put them into the 51 system. In fact, there's been a Supreme Court case saying that those systems are not the same and you should not be having an emergency detention. But that case involves an elderly woman who was in a nursing home, and the nursing home didn't know how to deal with the behaviors caused by the dementia. So they ended up doing an emergency detention, and she got into the 51 system. She did not belong in the 51 system. And the Supreme Court found that and said that they need to be in the protective services system. And there should be, we've had several cases at DRW in the last year where someone with a developmental disability ended up in a general hospital in restraints for weeks and months because they didn't know what to do. And they needed an emergency support system. They needed services that are not necessarily the classic Chapter 51 services, psychiatric services, to deal with that individual. So I don't think it does any good to try and lump anyone who has something that has to do with their mental health or their brain, whether it's organic or trauma or however it comes about, into one size fits all. And I think we need to make clear that we need to figure out what's going on with an individual and then help that person or their guardian or whoever choose a path for them that will help them make the best progress with their where they're at in this crisis situation. So I really don't want to meddle up dementia and what we need to do for folks who are in having a behavioral issue that related to the dementia separate. There are individuals with dementia who also have a diagnosable mental illness. But I think the mental health system is misused by individuals that need a crisis response right now. This person is out of control. I don't know what to do. Call the police, start an ED, start a 51. And that is not the way this should progress. And that's not the road that individual needs to go down to get the help they need.
Thanks, Kit. We're almost out of time. As you could tell, we could probably have a much longer discussion with a number of other stakeholders too on the panel. But I do have one final question I was hoping that everyone could kind of address. The reforms we talked about will likely take some time and money. What type of change do you think is needed first and most quickly? And why don't we start with the Attorney General?
Thanks, Sharon. I think one of the topics we've talked about today is one where there can be fairly quick implementation, and that is figuring out a way where our crisis responses can happen so that it's not exclusively a law enforcement response in a lot of the state. I think there are ways that we could create incentive programs, and actually there have been pilot programs previously created. I also think we can put some steps in place to streamline the emergency detention process so it's not as burdensome on everybody involved, like having a common form that's used when the health assessment is conducted. You're right that investing in a continuum of care model is going to take some time, but I also think now is a great opportunity for us to do that, to make sure that we're prepared for the challenges that are going to be facing us in the future.
Thanks. Senator?
Thank you. I think we can do better on the telehealth, and if we need additional legislation to bring that to fruition. I know we have Act 56 that has facilitated some of that as well currently. And for my region of the state, the one thing I can do right now is create regional mental health care, bearing in mind that HSHS does voluntary mental health care, not just Chapter 51, and understanding that they will take Chapter 51, keep them from having to go all the way to Winnebago to keep our citizens from the Northwest region of the state more locally. and where they can get their natural supports from family members and friends.
Thank you. Pete?
I would vote for telehealth. I think that telehealth could enable other things to get done more quickly and solve some of the issues that we've got just immediately. So that would be my vote.
Thanks. Todd?
Yeah, we need statewide implementation of evidence-based programs and practices, and we need to be able to fund those sufficiently. Telehealth is a quick way to get there, but there are evidence-based solutions out there. The more local and the more community-based they are, the more effective they are.
Thanks. Kit?
Drastically increase investment in services upstream. All but 8 counties in the state of Wisconsin are federally designated mental health professional shortage areas. It's a statewide problem, along with housing, food security, access to health care. Healthy people, they have less problems with crisis because they're able to have full and stabilized lives. And we need to start way back up at the beginning with money, with investment in our citizens.
Thanks. And Kim?
I would say in like expanding Medicaid to reach more people. There was one point this summer where I was on a medication that would be $1,500 on my own. And that keeps you from being able to get the care that you need. So I would expand Medicare or Medicaid, and also just keep investing in peer specialists.
All right. Well, thank you to all the panelists, and thank you for tuning in. Next week, we're going to be having a discussion with Governor Tony Evers on his budget plan. So if you want to tune into that, that'd be great. Thanks once again to everyone for joining and for participating.
Thank you.